This is part 9. In this part, I will continue talking about intracorneal ring segments. In this part, I will discuss my own customized method. At the beginning of the video, I will mention the causes why I shifted to this customized method. Then, I will present the steps of this method, and at the end, I will discuss some clinical cases that will be studied as examples. I hope you will enjoy. Section 3. Intracorneal ring segments. The customized method. First, I will present why I shifted to the customized method. First, because K readings are not included in the nomogram in the traditional method. Of course, I cannot deal with these two corneas similarly. A cornea with 47 diopters of maximum K reading will present a response that is different from another cornea having almost 55 diopters of maximum K readings. So I have to consider the K readings in my calculations. Second, cone location is not considered also in the nomogram calculations. And logically, when we have keratoconus with central cone, it will respond very differently from another one having peripheral cone or paracentral cone. So each cone location has its own response. So I have to consider cone location in my calculations also. Third, comma axis is not always accurate, as in this example. You see here, the comma axis is right perpendicular to the clinical axis and topographical axis. So I cannot depend on comma axis. Fourth, the manufacturer recommends the 6 mm type when the mesopic pupil is larger than 5 mm, and this is true. When the depth ability is beyond safety limits, and this is also true. And when we are planning for another step like topography guided PRK or phakic IOL, and this is also true. But the manufacturer recommends the 6 mm type when the astigmatism is less than 5 diopters, and this is not correct. Why? Depending on clinical observation and also from my experience, the 6 mm type is very beneficial when the sphere is low and the astigmatism is high. I'll show you this example. This is a case of keratoconus. This is the preoperative topography. The patient has high astigmatism, almost -9 diopters. On the left, we can see the preoperative data. The patient had almost -9 diopters. In the middle, the postoperative data. The patient improved and had only -1 diopter. So the difference map on the right shows almost -8 diopters of improvement. Fifth, the manifest refraction. In keratoconus, the manifest refraction can be considered realistic or accurate just in early cases, but in grade 2 or 3, where the intracorneal rings are indicated, the cornea is distorted and the manifest refraction does not reflect the real refraction of the patient. So I cannot depend on the manifest refraction in cases where the intracorneal rings are indicated, because in these cases, the patient has high irregular astigmatism and high order aberrations. And we have to put in mind that the field of action of the intracorneal rings is in the cornea. So we have to consider the refraction of the cornea itself. I mean by that the topographical astigmatism. Number 6, the depth of tunnel. Some studies recommend the 70% of corneal thickness without mentioning the meaning of corneal thickness. Is it the central thickness? Is it the thinnest location? Is it the thickness along the tunnel or at the incision? While other studies recommend 70% of the lowest thickness along the tunnel, and some studies also recommend 70% at incision site. And you may find some studies recommending 80% instead of 70%. Actually, we cannot depend on the site of incision to take 70% of it, especially when we have inferior keratoconus like pellucid-like keratoconus or the pellucid marginal degeneration, because in these cases, if we create the tunnel near the thinnest location and we consider the thickness at the incision site, then we will exceed the thickness at the thinnest location, as here in this example, and we may have a perforation. The same may happen also when we consider only the thickness, the lowest thickness along the tunnel. And the risk of perforation is higher when we use the femtosecond. Why? Because in the manual technique, we are creating the incision and we are then dissecting in one level in between the layers. While in femtosecond laser, we are applanating the cornea, and because of the difference between the outbulging or the difference in outbulging between the posterior surface and the anterior surface of the cornea, the thickness along the applanated area is not homogeneous, and you know that the femtosecond is creating a layer of air bubbles. It is not dissecting between layers. It is creating a layer through the lamellae, and therefore it may cut through the lamellae if we are very approximate to the thinnest location. So the risk of perforation is higher with the femtosecond laser in cases where the thinnest location is vertically dislocated, as in inferior keratoconus or pellucid marginal degeneration. So in these cases, of course, we cannot take just very simply consider the thickness at this incision or along the tunnel. In these cases, it's better to consider the 80% of the thinnest location. How to calculate it? In order to calculate the size, diameter, and thickness of the segment, we have to measure the refractive error, the mesopic pupil, and to know which nomogram to go for. We will start with the refractive error. In this customized method, I will go for final sphere and topographical astigmatism. Now, what is the final sphere? The final sphere is manifest sphere plus Kmax factor. Now, the Kmax can be taken from the data of the pentacam as displayed in the parameters, and the Kmax factor idea came from the location of the cone. Now, in cases of paracentral or peripheral cones, if we implant the ring will push the cone towards the center, and the K readings in the center will be higher than preoperatively, and therefore the spherical component of the refractive error will be higher, although the cone itself will be flattened. The Kmax factor equals 0 when the cone is central, because it is already central and it will be flattened. While when it is paracentral cone or peripheral cone, the Kmax factor should be considered for this reason. The nomogram of Kmax factor is, as you see here, we add something to the sphere according to the amount or to the number of Kmax. And we will take some examples. Example number 1, the manifest refraction is -4 diopters. The Kmax of the patient is 58. So I'm going to add -1.5 diopters to the manifest sphere, and the final sphere will be -5.5 diopters. Another example, manifest refraction is -5. The Kmax of the patient is 54. So -1 diopter will be added to the manifest sphere, and the final sphere will be -6 diopters. Example number 3, the manifest refraction is -3. The Kmax in the patient is 51, and the final sphere will be -3.5 diopters. Next, we calculate the topographic astigmatism. The topographic astigmatism is the algebraic sum of the astigmatism of the anterior and posterior corneal surfaces, and we have to pay attention to the axis of the astigmatism on both surfaces. They should be same or approximately same. Now, in this example, the topographic astigmatism is the algebraic sum of the anterior and posterior corneal surfaces, and it is plus 6.4, and approximately it is 6 diopters. After we calculate the algebraic sum, we take the absolute value and we keep it in the table as in minus. So whatever it is, minus or plus, we take the absolute value after the algebraic sum and we keep it in minus in order to use it in the nomogram for calculations. This is example number 2. The topographical astigmatism in this case equals plus 8.7, approximately 9. So it is 9 diopters, and I will use it as -9 diopters in the table. This is example number 3. The topographical astigmatism equals -5 diopters. The mesopic pupil. As in the traditional method, when the mesopic pupil diameter is smaller than 5 mm, we can use both, but it is mandatory to use the 6 mm type when the pupil diameter is larger than 5 mm. Regarding the nomogram, in the traditional method, we mentioned that in this method, the anterior sagittal curvature map is used, and the determined axis is drawn on this map, and according to the asymmetry pattern on both sides of this axis, the shape will be matched with the illustrations provided by the manufacturer in Table 1, corneal asymmetry type classification, and in this example it is type 2, so we have to go for nomogram A. But I don't use this method. I use the posterior best fit sphere elevation map, and I see the cone, whether it is central, paracentral, or peripheral. In this picture, the cone is central because its apex lies within the central 3 mm zone. This is a paracentral cone because its apex lies between the 3 and the 5 mm central zones. And this is a peripheral cone because the apex is outside the 5 mm zone. When the cone is central, I go for nomogram C. When it is paracentral, I go for nomogram B. And when it is peripheral, I go for nomogram A. Just to remember, the 6 mm nomogram is just the 5 mm nomogram. But after calculating the measurements of the segments on the nomogram, which is 5 mm nomogram, and we decide if we decide to go for the 6mm type, very simply, we have to add 50 microns to the thickness, and if the segment is 160, we use 150 instead. Like in this example, if it is type 5, 160, 200 microns, it will be 150, 250 microns. And the 120, 150 microns will be 120, 200 microns. And the 90 to 250 microns will be 90, 300 microns. Now, when the 6mm type is indicated, this depends on refraction, cone location, the mesopic pupil, depth ability, and planning for another step. Let's start with the refraction. When there is no spherical component and we have astigmatism, or the spherical component is in plus, or when we have low spherical component with high astigmatism. In these cases, the 6mm type is indicated. Second, when cone location is peripheral, it is mandatory to use the 6mm type, because if we use the 5mm type, we are going through the apex of the cone. When the mesopic pupil is larger than 5mm, it is mandatory to use the 6mm type. Regarding depth ability, if we are planning to use the 5mm type and we came to the ability of depth and we found that the depth is not sufficient at the site of the 5mm type, in this case, either we go to reduce the thickness of the segment and keep it 5mm type, and this will be on the account of the spherical correction. This will reduce the spherical correction of the segment, or we go for the 6mm type because it will be implanted in a more peripheral part of the cornea, which is supposed to be thicker. Number 5, if we are planning for another step like topographic guided treatment or phakic IOL. We will take 3 examples to apply all the steps that I have mentioned. Example number 1. This is the topography of a patient. This is the right eye. This is the right eye refraction. The patient has manifest sphere, manifest refraction, -3 sphere, -5 cylinder at axis 15. His incorrect visual acuity is 0.16. Best correct visual acuity is 0.6. First, I want to know whether I need to add Kmax factor or not. So I go to the posterior elevation map in best fit sphere mode and see what is the classification of the cone. In this case, it is paracentral, so I need to add Kmax factor. So I look for the value of Kmax and match it with the table of Nomogram. In this case, I have to add -1 diopter, and the final sphere will be -4 diopters. The topographical astigmatism is calculated as an algebraic sum, paying attention to the axis of the 2 surfaces, and in this case, the topographic astigmatism is almost -5 diopters. The mesopic pupil is smaller than 5mm. And to know which nomogram, we look again at the posterior elevation map in best fit sphere mode. And since the cone is paracentral, we go for nomogram B. This is nomogram B. The patient has -4 diopters sphere and -5 diopters cylinder. So we have to use 2 segments. One is 160, 200 microns, and the other one is 160, 300 microns. So the final measurements are 5 millimeter type, 2 segments, 160, 200, and 160, 300. Example number 2. This is the topography of a keratoconus in the left eye. The refraction of the patient is -5 diopters sphere, -4 diopters cylinder at axis 170. His uncorrected visual acuity is 0.05 decimal, and the best correct visual acuity is 0.7 decimal. Starting with the sphere, we look at the posterior elevation map in the best fit sphere mode to know whether to go for the or to add the Kmax factor or not. Now, in this case, the cone is central, so the final sphere equals the manifest sphere. We go for the topographic astigmatism. It is the algebraic sum of both surfaces, and in this case, it is almost -3 diopters. The mesopic pupil is smaller than 5 millimeter. And for the nomogram, since it is central cone, we go for nomogram C. And this is nomogram C. The patient has -5 diopters sphere, -3 diopters cylinder. So if we are going to use the 5 millimeter type, we need to use 2 similar segments. Each one is 160 diopter, 160 degree, 250 microns. Example number 3. This is a keratoconus case in the left eye. The patient has +1 sphere, -5 diopters cylinder at 95. It is against the rule astigmatism. Incorrect visual acuity is 0.4. Best correct visual acuity is 0.7. We start with the sphere, and to know whether to include the Kmax factor or not, we look at the posterior elevation map. In this case, it is a paracentral cone, so we have to consider the Kmax factor. In this case, the final sphere is 0. Regarding the topographic astigmatism, it is the algebraic sum, and in this case, it is approximately 5 diopters. Although it is M+, but I'm going to use it, as you see here in the table, as -5 diopters. Now, the mesopic pupil is smaller than 5 millimeter. And for the nomogram, this case is typical or identical for the 6 millimeter type. Since the cone is paracentral, I'm going to use the nomogram B. This is nomogram B. The patient has 0 sphere and -5 diopters cylinder. So the measurements in this case are 120, 200 microns, 120, 250 microns. But since I'm going to use the type 6 millimeter type, the measurements will be 120, 250, and 120, 300 microns, because we have to add 50 microns to the thickness. The third question in this customized method, where to implant it? We have to determine the axis, the depth, and the ability of the depth. Regarding the axis, I use the customized axis. Let's take this shape as an example. As you know, this is asymmetric bowtie with skewed radial axis. In this case, I draw a line through the center of the cornea, which divides the upper parts of the segments into 2 humps. And each hump should have the same height of the other one. This is another example. I draw a line through the center of the cornea, and we have two humps with same height. This is another example. And this is another example. This is the right eye. You see that the black line divides the shape into upper nasal and lower temporal. Now the upper nasal has two humps. The two humps should have same height. Now regarding the depth, after I determine the axis of the patient, I draw this axis on the pachymetry map, and I determine the depth at incision site by multiplying the thinnest location by 80%, and in this example it is 375 microns. Then I check the ability of depth by measuring the minimal thickness along the segment tunnel and compare it with the corneal pachymetry safety limits reference table. And according to that, either I go straightforward with the segments, the measured segments, or if it is not applicable, either we reduce the thickness by 50 microns, and this will reduce the spherical correction, or if we are using the 5 millimeter, we convert into 6 millimeter type because they are implanted in more peripheral part of the cornea, which is supposed to be thicker. So what is the customized plan? Measuring refraction and visual acuity, measuring mesopic pupil, determining the axis, determining the proper nomogram, measuring the depth, and checking the ability of the depth. We will go through 3 clinical examples that will be studied in order to apply this systematic plan. Case number 1. This is a left eye of the left eye of a patient with keratoconus. This is his refraction and his visual acuity. Now, since the cone is central, the Kmax factor is 0. So the final sphere is just the same as the manifest sphere. Regarding the topographical astigmatism, it is the algebraic sum, and in this case it is -3 diopters. The mesopic pupil is smaller than 5 millimeter. To determine the axis, I draw a line through the center of the cornea, and in this case it is 35 degrees. To determine the nomogram, we look at the elevation map. It is a central cone, so we go for nomogram C. In nomogram C, the patient has -2 sphere, -3 cylinder, so we have to use 2 similar segments, 160 to 100 microns. So the first segment is 160 to 100 microns, will be implanted in the superior nasal part of the cornea, and the other one is also 160 to 100 microns. It will be implanted in the inferior temporal part of the cornea, and both will be 5 millimeter type. Regarding the depth at the incision, it will be 320 microns. And to check the ability of the depth, since it is 200 microns, the segment, so the minimal thickness should be 335, which is available in this case. So the measurements are type 5 millimeter in the left eye, 2 segments, one in the superior nasal part and one in the inferior temporal part. Both are 160 to 100 microns. The axis is 35 and at the depth of 320 microns. Case number 2, the right eye of a patient with keratoconus. This is his refraction and his visual acuity. Since it is paracentral cone, so I have to consider Kmax factor, and the final sphere will be minus 5.5 diopters. The topographical astigmatism is 7 diopters, so I'll put it in the table as minus 7 diopters. The mesopic pupil is smaller than 5 millimeter. This is the axis. It is 150. Since the cone is paracentral, I'm going to use nomogram B. Now, since we have high astigmatism and relatively high sphere, we can go for 5 millimeter type in order to correct some astigmatism and some sphere, or we may go for 6 millimeter type in order to correct most of the cylinder and some of the sphere. This is nomogram B. Now, as you see, the patient has minus 7 diopters cylinder and 5.5 diopters. Now, either we can go for the 5 diopters of sphere column or for the 6 diopter column. Now, fortunately, the measurements are just the same in these two columns. So the measurements will be 160, 200, and 160, 300. So if we are going to use the 5 millimeter nomogram, the measurements will be 160, 200, and 160, 300. And if we want to use the 6 millimeter type, the measurements will be 150, 250 microns, 150, 350 microns. The first segment is inferotemporal, and it is 160, 300. We use the thicker one inferiorly. And the superior nasal one will be 160, 200 microns. But if we are going to use the 6 millimeter type, the 150, 350 will be inferotemporal, and the 150, 250 will be superior nasal. Regarding the depth at incision, it will be 341 microns. And to check the ability, one is 200 microns. So the minimal thickness will be should be 335, which is available as we see here, and the other one should be at least 500 microns, and also it is available. And if we are going to use the 6 millimeter type, the rings will be in more peripheral position, and also the ability of depth is available. So the measurements will be, if we are going to use the 5 millimeter type in the right eye, there will be two segments, one superior nasal, 160, 200. The other one is inferotemporal, 160, 300 microns. Around axis 150, in a depth of 341 microns. And if we are going to use the 6 millimeter type in the right eye, we will have two segments. One is superior nasal, 150, 250 microns, and the other one is inferotemporal, 150, 350 microns, around the axis 150, with a depth of 341. Now, case number 3. This is the topography of the right eye of a patient with keratoconus. This is his refraction and incorrect and best correct visual acuity. Regarding the sphere, the cone is peripheral, so we have to consider Kmax factor, and the final sphere will be -1. The topographical astigmatism is 6 diopters, and the mesopic pupil is smaller than 5 millimeter. Since the patient has low sphere with high cylinder, it is typical or identical for the 6 millimeter type. And because the cone is peripheral, we have to use Nomogram A. This is Nomogram A. The patient has -1 sphere and -6 cylinder. So we have to use 2 segments. One is 90, 150, and the other one is 160, 300. But because we are going to use the 6 millimeter type, the measurements will be 90, 200 microns, 150, 350. This is the axis that I'm going to use. It is 160. One will be inferior temporal, 150, 350. And the smaller one and the thinner one will be superior nasal, 90, 200 microns. Regarding the depth of the tunnel at the incision, it is calculated by using the thinnest location. In this case, it is 362. And to check the ability, we will start with the upper segment. Because it is 200 micron thickness, the minimal thickness needed is 335, and it is available. Now for the lower segment, it is 350, and the minimal thickness should be 580. Now let's remove this segment away. Actually, the thickness available in this site is not sufficient according to the corneal pachymetry safety limits reference table. So in this case, we have to reduce, because it is already 6 millimeter type, so we have to reduce the thickness of both segments, not only the inferior one. We should reduce the thickness by 50 microns for both, and in this case, the ability of depth will be applicable. So the measurements will be 6 millimeter type in the right eye, 2 segments. One is superior nasal, 90, 150, and another one is inferior temporal, 150, 300. And because we reduced the thickness by 50, this will be on the account of the spherical correction, which is not a matter in the 6 millimeter type. The axis that should be used is 160, and the depth is 362. So to sum up, we have to determine refraction and visual acuity, mesopic pupil, axis, nomogram, depth of insertion, and finally to check the ability of depth. Thank you very much. This is the end of part 9. Thank you for listening. In the coming part 10, the mirroring will be discussed in details in terms of indications, contraindications, and conditions. Goodbye.